I'm honoured. I think getting voted by students is one of the most humbling experiences that you can have. You can get all kinds of prizes, grant funding, and opportunities, and you can appear on television and get hobnobbing with parliamentarians. But I think to get students voting for you is very humbling. So thank you. Thank you very much. The title, The Past, Present and Future of Male Fertility, is deliberately vague because when I was asked for a title, I wasn't quite sure what I was going to say. But I am going to be true to the title, and I'm going to tell you a little bit about the history, a little bit about the present, and a little bit about where we might be going with regard to male fertility. And it's hard, really, to know where to begin. Where does the past begin? If you read back in the history books, our knowledge of human reproduction has for many years been, or was for many years, rather vague. And piecing together the elements to understand what made successful reproduction took a long time. If we go back to Hippocrates, Aristotle and Galen, they all knew that successful reproduction was down to the conjugation in some way of male and female. But they couldn't quite understand what the detail was, and there were arguments on both sides. It was thought that the new infant, the baby, came from the female but was simply nourished by semen from the male. There was no concept that there was this thing called fertilization. And even people as eminent as William Harvey was the man that worked out that the heart circulated blood around the body, had to conclude that the female was fertilized by some kind of spiritual irradiation. So when kind of working out when the beginning was, in my mind, it all really starts with the discovery of sperm. And for the discovery of the sperm, we have to thank this man. This was Anton Philipp van Leeuwenhoek, who, as you will have guessed, was a Dutchman. But he wasn't a scientist. He was a draper. And he started to get interested in microscopes and making things bigger and magnifying things because he was interested in understanding the quality of his cloth that he worked with as a draper. But having an inquiring mind meant that he started to consider other things. And he soon became well known around the world for describing very small things. He was the first to give a detailed description of the sting of a bee. He looked at algae and ciliates from pond water. He looked at various animal and plant tissue. He looked at fossils and minerals. He looked at very small animals, nematodes, rotifers. He was one of the first to describe red blood cells. And he looked at the plaque of his own teeth, and also the plaque from two ladies, probably his wife and his daughter, and it said the plaque from two old men who'd never brushed their teeth in their lives. And he described bacteria. That's his early microscope. Looks a bit like a door handle, I suppose. If anybody ever wants to buy me a present, perhaps a leaving present when I leave the university, then something like that would really do the ticket. I expect an original is very expensive. So you can see, an inquiring mind, an early microscope, it's only a matter of time before a man makes the connection and decides to look at his own sperm. And that's what he did. And these were the early drawings of those sperm samples that he looked at. And by modern standards, yes, not great, but actually, given the optics of the day, not that bad either. And I think we really owe the beginnings of male fertility research to him. He wrote a fabulous letter to the Royal Society describing the discovery of sperm. And when I write papers and I send them off to editors to consider them for publication, I write a very nice covering letter on university letterhead that says, "Dear sir, please find enclosed my paper on so-and-so, so-and-so. Would you consider it for your journal?" he wrote something remarkable. He wrote, "What I investigate is only what, without sinfully defiling myself, remains as a residue after conjugal coitus. And if your lordship should consider that these observations may disgust or scandalize the learned, I earnestly beg your lordships to regard them as private and to publish or destroy them as your lordships see fit." They didn't, they published, and the rest is history. But it wasn't without controversy. There were people like this chap who published a letter in the same year hypothesizing that what Van Leeuwenhoek had seen were little vessels in which a very small person would sit. And that was how the woman became pregnant, because a very small person was delivered into her reproductive tract. I don't think he ever claimed to have seen this. He was simply hypothesizing. But you can see how the mind of people was really triggered by these observations. And as we move on, we've got to thank this chap, John Hunter, perhaps the most famous surgeon in English history, if not the world. He was a Scot. He could hardly read and write. He left school at 13. He would have been eligible for widening participation. But at age, I think, 20, he went to London to join his brother, who'd opened an anatomy school in Covent Garden. And it was John Hunter's job to get the bodies for dissection. He used to take parties of medical students out to the graves of paupers to dig up the bodies to dissect. It's claimed he dissected over 2,000 bodies, but finally got bored with working for his brother and went eventually for a career in medicine himself, first as an army surgeon and then becoming a surgeon to very many famous people in London at the time. He pioneered tooth transplants. That didn't take off and was banned. But he became an expert in venereal disease. And he published a work on venereal disease in 1786. His famous experiment, it is claimed, was that, it's claimed, I don't believe that it's true, that he infected himself or attempted to infect himself with gonorrhea by injecting himself with the pus from somebody who had gonorrhea. But it's claimed that he also contracted syphilis as well. And that led to a 50-year period of history where people thought that gonorrhea and syphilis were caused by the same organism. It wasn't the case. It was just that the person that he got the pus from had syphilis as well. That's taking experimentation, I think, to a whole new level. People have questioned whether or not it was actually him that he infected. I'm sure it was some poor soul that he paid a few pence to do that experiment. I'm sure he didn't do it on himself, but who knows. But he certainly was an enthusiastic researcher. He once described, and I'll leave this to your imagination, he once described that semen would appear both from smell and taste to be a mawkish kind of substance, but when held some time in the mouth, produces a warmth similar to spices, which lasts some time. One hopes the semen that he tasted was his own. But his contribution to male fertility research was more than just as a sperm taster of 1790, because he was the first to suggest that artificial insemination might be a solution to male infertility. And he advised one of his patients, a cloth merchant, who had what could only be described as severe hyperspadias. That's a malformation of the penis where the semen doesn't always come out at the end. It can come out of holes in the side or beneath. And he advised this man to collect the semen and to inseminate it into his wife using a warmed syringe. And she got pregnant. And that was the first historical description that we know of artificial insemination. How widely it was used is really unclear. But But our next recorded episode in history took place in the United States in 1884 at this place, the Jefferson Medical College in Philadelphia. And this is really famous in male fertility circles. The doctor was a William Pancoast. He had a patient who, a couple where they were failing to get pregnant. He examined the female partner, couldn't find anything wrong, so he turned his attention to the male, and he found that the male had no sperm in his semen. It's probably one of the first descriptions of what we now know as semen analysis. And he didn't know what to do. So he presented this conundrum to a class of his medical students. And some bright spark, after some discussion, probably some cheeky boy at the back, said that the way to solve this conundrum was to get some semen from the best-looking medical student in the class, the best-looking male medical student, and to inseminate the woman in order that she got pregnant, and then she might have a child. And that's exactly what he did. He got the couple back. He anaesthetized the woman on the pretext of performing an examination, but one assumes in the next room the medical student was producing a specimen that was rushed through into the operating theatre. She was inseminated, and a baby she fell pregnant, and a baby ultimately was born. Dr. William Pancoast didn't tell the woman that she was getting inseminated with sperm from the best-looking medical student in the class, but confided in the woman's husband, who, it's alleged, said, "Thank you very much. Please don't tell the wife." Now, I always thought that the donor-conceived child never knew that that's how he or she was born, but actually in doing some reading at the weekend, that's not true. The donor-conceived child eventually knew, but I don't know how he or she knew. No, it was a son, how he knew that he was conceived that way and had managed to keep it from his mother. So, donor insemination, 1884. Remarkably early in our history when you think about it. And how widely it was used is pretty unknown until 1945, when in the British Medical Journal, a lady called Mary Barton published a paper describing her clinic in London that specialised in helping couples conceive using donor sperm. There was an outcry. Parliament debated the legality and the morality of this. The Pope declared it a sin. There were calls for it to be made illegal. And there was a church commission that was established to look into it and see whether or not it was something that should be supported or made unlawful. At an interesting time, Parliament decided that they wouldn't make it illegal. But it's interesting that that left doctors who practiced it in a kind of quasi-legal state. It was frowned upon but not made illegal. The provenance or the role that the father had legally, the social father, was not clear. What you put on the birth certificate, that was not clear. It was really done in secret, kind of backstreet operations. The paper describes in some great detail how donors were recruited and how they were screened. There was some attempt to make sure that this was done safe. Remember, we couldn't freeze sperm at this point, so these women were getting seminated with fresh sperm, and that has risks associated with it, and those risks were known. So there was great stress put on how the donors were recruited. We now know, of course, that the third author in the paper, Bert Holtz Weisner, who was the husband of Mary Barton, was probably one of the only donors. And I was called by the Sunday Times a few years ago to ask for my views on this and how many children he'd probably fathered. And we had to conclude after a bit of calculation that it was probably around 600. So he was a very fertile chap. But of course, nobody knew that until more recently. Another part of our history, in 1953, we worked out how to freeze sperm and freeze it first in dry ice, but ultimately in liquid nitrogen. And that really revolutionized things in many ways. We could freeze sperm from men who were about to have treatment for cancer. Cancer treatments often make men sterile. So by freezing it before treatment, you give them hope of some future fatherhood. But it also allowed for sperm banks to be created. So at some point following 1953, and I suspect in the late 60s, early 70s, people really started to think about developing sperm banks. The earliest sperm around the world, the earliest sperm bank I know of in the UK was about 1973, 74. So freezing sperm has really changed things, but opened up some really interesting political, social issues. And I just wanted to highlight a book that is a good read if you're into popular science books. It was published a few years ago, 2005, and it's called The Genius Factory. And it's the story of an eccentric millionaire by the name of Robert Graham, who believed that America was facing genetic catastrophe. And so he decided that he could reverse the decline by artificially inseminating women with the sperm from geniuses. And he went all out to recruit inventors, gifted scientists, thinkers. He wanted Nobel Prize winners, but I don't think anybody agreed to donate for him. But it lasted for about 19 years. We think about 200 children were born. And it's a real interesting insight into life in America, but also sperm banks in that period of our history. So, in terms of treating male fertility, we could help with some artificial insemination like Hunter. We could do some donor sperm treatments, but really we couldn't do much more. And the thing that changed it radically was the invention of IVF, in vitro fertilization, in 1978. IVF was developed largely as a solution to infertility where the fallopian tubes of a woman were blocked. But in order to get IVF to work, Patrick Steptoe had to work out how to get sperm to fertilize an egg in the lab. And that's incredibly hard, believe it or not. Sperm that are ejaculated by a man are not really fertile unless they've spent a bit of time kind of incubating inside the woman's body. And he had to try and replicate that in the test tube. And it took him a long time, but eventually he was able to do that. But it was more than that. He paved the way for scientists like me and others to start thinking about how you might help men where there were really low numbers of sperm in their ejaculates. And people started playing around with needles and moving sperm around in dishes to try and get them that bit closer to the egg. People used to kind of take the sperm and put it really close to the egg in the hope that you've got it to within a few microns that it might suddenly jump and fertilize the egg that bit better. I'll come back to that because really that's now the mainstay of our current treatments that we have in fertility. So, the present. I'm surprised how interested people are in fertility. I get called by the newspapers quite regularly, television companies. I give talks to members of the public, and I'm constantly asked for my view about this, that, and the other. It is a fascinating area of medicine, and I'm going to skim over so much detail I'm embarrassed, but I think there's only a few things that you really need to know about what we think is important in male fertility terms. The first is to acknowledge that we now know that men have the potential to produce sperm almost throughout their entire life. Men start producing sperm as they go through puberty, and then they don't stop unless they have their testicles removed or they have an accident and they're damaged, or perhaps they have cancer treatment. But in somebody with an unremarkable medical history, they have the potential to produce sperm throughout their lives. And that's perhaps best illustrated by Charlie Chaplin, who fathered his 11th child to his 4th wife at the age of 73. Now that's unusual. Most men don't father children when they're 73, but then I'd argue that most men are not millionaires and don't go through multiple wives, and I suspect there's a correlation there between being a millionaire and getting a younger wife, but that's perhaps me being cynical. The second thing is that it takes a long time to produce a sperm. We think it takes about 3 months, and it's an incredibly technical process that happens in the testes. You have a group of cells in the testes called testicular stem cells. They go down this differentiation pathway. They change size and shape. They halve the amount of genetic material that they're containing. They grow a tail, and eventually they're ready to be ejaculated in the form that we currently know or recognize. That's important to recognize because many men go on kind of health drives and they think, well, I'm ready to become a dad, I need to get healthy, and I'll stop smoking and I'll reduce my alcohol consumption. Well, if you do that, if you stop smoking on Friday, your sperm isn't going to have improved by Monday. It needs to be a coordinated, sustained change in a man's life. And when we're looking at sperm that a man has produced in the lab, we're actually looking back in time, and we're looking at things that started to happen 3 months before. The second thing we need to know about male fertility, and perhaps the thing we need to know about males, is in fertility terms, I'm afraid, bigger balls are better. There is a correlation between the size of a man's testicles, that's on the right, the bottom, and the number of sperm that he will ejaculate. And that's because the bigger testicles that he has, the more sperm-producing machinery he has. In the clinic, we have something that looks like this. It's a series of beads that are calibrated to measure against so we can work out a man's testicular size. It's called an orchidometer. It's a great thing to take to parties when you're playing games about what's the object. And they're made of wood. The modern ones are made of plastic. This is an antique. So, don't forget, testicular size is important. And the next thing to realize is the fact that more sperm, the better. The more sperm that a man ejaculates, everything else being equal, then the more likely he is to conceive with his partner. And this data here shows data from 430 Danish men that were beginning the process of trying for a family with their partners. And what you see on the vertical axis there is the probability of them getting their partners pregnant over 6 months. It's a numbers game. It's all about probability. The more sperm you have, related to how big your balls are, and of course, to some extent, the more that you try. But you get to a point where having more sperm, once you get above about 50 million sperm, you're not going to improve your chances. But in this kind of 0 to 50 phase, there's a fairly linear relationship between the probability of conception and the probability of success. But not everybody manages it. And when that happens, we need to make a test. And we call that test semen analysis. And that's where a man comes to a clinic like the one that I look after in the Jessup wing, and we ask him to produce a specimen, and then we put that specimen in the lab and we make measurements. We ask the man to produce a specimen in a container that looks like that. And when I went to the lab today and said, can I have a specimen? I'm giving a lecture, can I have a specimen container? One of my scientists said, used or new? That's new. It's got a seal on it, so the man knows that the sperm that goes inside are from him. In the lab, we can measure how many sperm he has, sperm concentration. We can see how well that they swim by just looking at them, and we can also look at size and shape. And they're the values that we think are compatible with normal fertility. Fall below those, and the doctor will say, you possibly, sir, have a fertility problem. And we think about 20% of young men these days have a sperm quality that falls below those values. By the time you get to the infertility clinic and you're ready to provide some treatment, it's interesting that if you're to classify why the couple in front of you have a fertility problem, the reasons are split 50-50. Half of the time they're down to problems with female physiology, and half of the time they're down to problems with male physiology. And I think in the West, we've kind of finally got that message through, but there are parts of the world, and particularly in developing countries, where we still are, or the public are still confusing fertility with potency, and that men are very unwilling to accept the fact that because they can get an erection and can perform a sex act, that they still might be subfertile because they erroneously link one with the other. So, this is now our ultimate way of treating male subfertility. What you have here is, in the middle, that round thing is a human egg. It's been taken from a woman in a man's partner using the techniques that were developed by Steptoe and Edwards in the development of IVF. It's being held in place on the left by what we call a suction pipette, and in the right is a very fine needle in which the scientist has already placed a sperm. So in cases where the man's sperm is simply too weak or too few in number to fertilize an egg, we can do this. And what's happening is that the scientist is pushing that needle into the cytoplasm of the egg. There's the sperm inside that you'll see in a moment, just going backward. Can you see that little dot there? And then it's left inside. We perform that procedure. 30,000 couples have that procedure performed in the UK now. And around the world, perhaps even more numbers. In many countries, this is the fertilization method of preference. We still allow sperm when a man's got enough to kind of swim around the egg and fight their own way in. But in North America, 95% of all fertilizations are done like this. It's called intracytoplasmic sperm injection. So, what about the future? We've got a high-tech solution for male infertility. But what does the future hold for male infertility or male fertility per se? Are there any threats? Are there any new solutions? Well, let's begin with the threats, because people are still talking about whether or not we as a species are getting less fertile, and specifically whether men of today are less fertile than their fathers or their grandfathers. In my field, this is a hugely controversial topic, which really does divide opinion. You get people who think that we're on the edge of a cliff, and you get people who think that it's not as bad as people say. It was thrust into public consciousness in about 1992 when this now famous graph was published in the British Medical Journal, and it was a piece of work done by Danish scientists who looked at all the published records where sperm concentration or sperm count had been published over time, and then they plotted it on a graph, and you can see then drew that dotted line to connect those points in the most mathematically appropriate way, or so they thought. And you don't really have to be an expert to know that if that continues, we might arguably be facing a catastrophic loss of sperm in the human race in a century or two's time. And that sharpened the minds of researchers and policymakers and funders. But it was also highly criticized in the press. And by the press, I mean the scientific press. It was a look back in time. It was retrospective. Some people argued it was poorly controlled. Lots of the studies were from North America and Europe, with very few from elsewhere in the world. By its nature, these were men seeking fertility treatments, so were arguably already on the poor side. And then people started to criticize the statistical analysis. But it led to people around the world looking at their data. And my favorite paper is from Paris. allows me to show you a slide that I really like. So in Paris, your average Parisian male had a sperm count of 89 million per mil, so it's claimed. And then by 1992, that had gone down to 60 million. I despair at studies like that to some extent, because I think looking back in time is bad, because so much of what we did 10 or 15 years ago is bad by modern standards. So I don't think that's robust. Interestingly, in 2011, the results of the world's first and biggest prospective study were published. This is by the very group that started the debate in the first place. And what they found by looking each year at every new cohort of military recruits that were being assessed for military service, they found that if they looked in their sperm, that actually there had been no change over the past, well, from 96 to 2010. And people like me jumped on the bandwagon and said, well, hey, that is no coincidence. If you look back in time, you can't control for history, but if you look forward and you can control for history, it is not as bad as we all think. I'll skip that slide. But we are facing some threats. I think we're facing more threats from ourselves than we are from pesticides or coffee or cigarettes or alcohol, because society has changed. And this is data from the Office for National Statistics, looking at the mean age of maternity and paternity from 1964 to 2012. And the point is that we are getting older, or we're waiting until we're older before we're starting our families. And we know the dangers of waiting till you're older if you are a female. Risks of Down syndrome, for example, in women over the age of 35 is well described. But I think we've lulled ourselves into a false sense of security in thinking that men and older men can father children just as readily or just as easily as younger men can. And I don't think that's true. Here's some data from Bristol that looks at how likely you are to get your start a family depending on your age as a man or as a woman. And in this analysis, they controlled for each the age of the couple. It's some kind of clever statistics. And if you look at, I'm sorry, I've been terribly sexist and put the female bars in pink, but I think that means it's easy to look at. You see, as women get older, they get less fertile. But look at the blue. As their partners got older, they were less fertile also. And perhaps age had been harsher on them because the line or the bars are lower. When that data was published, the newspapers went mad, and they said that this shows that men have a menopause, just like women. I don't think men have a menopause. I just think they get old, and that their testicles start to wear out. And we can see the same kind of effects in infertility treatments now. So in some infertility treatments, we simply inseminate the sperm from the man into the woman, into her uterus, in a process known as IUI, intrauterine insemination. And what we see, if we look at that as a function of age, that on the left, success rates go down as the woman gets older, and miscarriage rates go up. That you would kind of expect that. We've known that for a while. But on the right, as the man who provided the sperm gets older, then success rates go down. But look what happens to the red line. The risk of miscarriage in his partner goes up when he is older. And I think that shows that men are not immune from reproductive aging. I could take it one step further. And this is a graph that I produced with a colleague from Oxford who's an evolutionary biologist, and we wrote a big review about the effects on fertility of getting having older sperm. And this was across the animal kingdom. These are odds ratios, so it shows you the odds of having a child with congenital malformations, Down syndrome, retinoblastoma, schizophrenia, or autism as a function of dad's age. There's no increased risk of having a congenital malformation as your dad gets older, but what this data shows is that once he gets above the age of 40, then your risk of getting all those other things increases statistically so that we can detect it in populations. And I think that's almost certainly telling us that as a man gets older, yes, he may well be able to produce sperm into his 70s, but those sperm that he does produce are not as healthy as they were when he was a young man. And I think that's just a function of age and a function of the aging process. But not many people really understand this data, and I think for an audience of young people like we have here, I think this is something to bear in mind when you're thinking about your own families. And the strong public health message that I will give is don't leave it too late. So what I've been talking about all the way through this talk really is about infertility and fertility related to a man and his sperm. But unfortunately, not all men have sperm. About 1% of men don't have sperm. And if you've had cancer treatment, you are likely, or highly likely, depending on the treatment, to suffer infertility as a consequence. So just to finish with the final bit of future gazing, it's interesting to consider whether we could ever make sperm for men. This man shown here once claimed that he did, and I claimed that he didn't, and we fell out in the media over it, and it was proven by fair means or foul later that he didn't. But that hasn't stopped scientists to try and make sperm in the lab for men who don't have sperm naturally themselves. People are also working on trying to make eggs for women. This is not just a sperm piece of research, but in the context of this talk, I think it would be very useful to try and hypothesize how long it's going to take before we successfully make sperm that men might use. And I think it's going to be within the next 5 to 10 years, because there's some very exciting animal data coming forward showing that you can generate sperm-like cells for animals, but somebody's yet to translate that into the human. Watch this space is really what I'm saying. So we have an interesting future. So, ladies and gentlemen, my time is almost up, and I feel I've barely scratched the surface. I've not told you half the things that we know about sperm. I've not told you about how they move, how they behave, how we select them in the clinic, and how we think that they are vectors of infection, believe it or not, in some sexually transmitted diseases. I've not told you half of the social, political, legal intrigue that sperm seems to throw up on a regular basis if you read the papers. If you want to know more about all those, you'll just have to vote for me another time, and I'll do another talk. But I'll leave you, I think, with one final thought, and this is Michelangelo's David. And if you're ever in Florence at the Academy Galleria and you get to stand at the bottom of this statue because it's high on a plinth, and you look up, I want you to look at David's testicles in comparison, and his penis by all accounts as well, in comparison to the size of his hands. Because, quite honestly, they are ridiculously small. And from my perspective, I think he may be having some trouble. Thank you very much.